Welcome, everyone. My name is Sabrina Shankman. I am a climate change reporter at the Boston Globe, and I am also today's moderator. Joining me today for this conversation, we have Amruta Nori-Sarma, an assistant professor of environmental health and population science at Harvard Chan School. We have Lisa Robinson, a senior research scientist at the Center for Health Decision Science at Harvard Chan School. And we're also joined by Caleb Dresser, an assistant professor of emergency medicine at Harvard Medical School. Thank you all for being here. Welcome. This event is presented jointly by the studio and the Center for Climate, Health, and Global Environment at the Harvard Chan School. So today we're going to be talking about something very timely if you're paying any attention to the news. We're going to be talking about the health impacts of extreme heat and some ways to mitigate them. So to start off, I'd love to just set the stakes. Amruta, are we having more spikes in extreme heat in the US and globally, or is that really just in our imaginations?
Thank you so much for the question, and thank you so much to Sabrina for moderating the panel today, and to my fellow panelists. It's really great to be here talking about this with all of you. So yes, it's not in our imaginations. We do know that, so I want to first set the stakes by talking about the fact that in the last decade, we've experienced all of the hottest years on record since we started recording global temperatures. According to a report that was released by the World Meteorological Organization in 2025, the 2024 was actually the third hottest year on record. 2016 smashed a lot of global temperature records. And what that means is at a baseline, we're already experiencing temperatures that are elevated compared to historical averages. So then once you start to see these extreme heat wave periods, which are happening more frequently, they're longer in duration, and the intensity of the extreme heat is increasing as well. That's on top of baseline temperatures that are already higher than what people are used to experiencing. So it is the case that we are seeing more frequent spikes of extreme heat, but it's also the case that we're experiencing hotter temperatures just on average at baseline as well.
And what do those risks look like? I mean, are these temperatures felt evenly, or is it distributed in a specific way?
So the reality of the situation is that some folks are at baseline more vulnerable to the adverse impacts of extreme heat exposure. So we know that people who are elderly, people with existing medical conditions, and people who are otherwise highly exposed. So people in outdoor construction work or agricultural work, people who spend a bulk of their time outdoors outside of climate controlled areas, experience the health impacts of extreme heat with more intensity than folks who maybe are employed in white collar jobs sitting indoors, or people who have better baseline health. And one of the things that I think is important to mention is that we think a lot when we're thinking about climate change, and I know you've thought about this a lot in your work reporting on climate change. We tend to think a lot about these really extreme disaster events. So we think about storms or flooding or wildfires. But the other thing about extreme heat is that it's really a silent threat. More people die because of extreme heat in the United States than the next few leading causes of extreme weather events combined. So we're already talking about elevated risk, and then we're talking about some folks who are more vulnerable compared to others. So it all adds up to a lot of potential vulnerability. And the last thing that I'll say is that when we're thinking about the global scale of extreme heat, we're thinking about average temperatures. But what's really important to highlight is that there are some communities across the US that are already experiencing those elevated temperatures, again, at baseline. So people who live in urban heat islands, for example, where temperatures tend to be a few degrees warmer than the peri-urban or the suburban environments, those folks may already be experiencing temperatures that are on average 2 or 3 degrees warmer than their neighbors. So it's important to think about vulnerability and risk across all of these different scales and metrics as well.
Yeah, it's fascinating how quickly it can change too. I know at the Globe, we've gone out with thermometers and shown how certain intersections can be several degrees hotter than just, a couple blocks away, having to do with that heat island effect that you're talking about. Now, it's not just, the human impacts, those ripple out, and there's like literal economic costs to extreme heat as well. Lisa, can you weigh in on what that looks like?
Oh, yeah, unquestionably. Some of these costs are direct economic impacts. If we don't feel well, we're less productive at work, we decrease the amount we produce and also our earnings. And of course, if we're sick enough to seek medical care, we as a society incur the cost of paying for the insurance as well as the out of pocket medical costs. What's more important, though, is that if our health is impaired, it has intangible effects like pain and suffering that we really want to take into account. A big challenge, however, is that resources are limited. If we use money to fund protective measures or to otherwise decrease our exposure to heat, we can't spend that same money on other things. This means that we need to choose wisely, assessing the costs and benefits of interventions to determine which will have the most beneficial impacts.
Yeah. Caleb, what do you see when it comes to working in the emergency department? What does an extremely hot day or an extremely hot string of days look like where you stand?
Surprisingly scary. Um, I work in an emergency department, actually, a couple of different emergency departments in the greater Boston area, which is not known for being a really hot part of the world. And I have seen more heat stroke and heat exhaustion and heat related illness than I ever expected to when I was training. Some of these cases are pretty scary. Classic heat stroke, exertional heat stroke, is a really intense critical illness situation. And from the standpoint of a treating team in an emergency department or a pre-hospital setting, these are resource intensive, time sensitive cases. And so that is certainly part of the face of this story is critically ill people needing rapid resuscitative measures, rapid cooling, cold water immersion if it's available. But there's another story, which is that a huge number of people who are using the emergency department during hot weather are there with something other than heat stroke or heat exhaustion. It may be that the hot weather and a bit of dehydration and inflammation has led to worsening of one of their cardiovascular conditions or respiratory conditions. It may be that some of the medications they're on have contributed to higher susceptibility during hot weather. It may be that their blood sugar is out of control. If you're diabetic and the weather is hot, it's hard to control your blood pressure and your blood sugar. And so what we see is both the critical illness cases, heat stroke cases, things like that, and a huge number of people with disease exacerbations. And just like Dr. Nori-Sarma was talking about how this is both a story of extremes, but also a story of increasing moderately hot conditions. Clinically, this is a story of some extreme cases and a lot of disease exacerbations. And what that can add up to is a strain on the system as a whole. When we've seen heat waves around the world in settings that have pretty functional emergency medical services systems and emergency care systems, in extreme hot weather, we actually do see increases in utilization that lead to longer response times for ambulances in some cases, higher 911 call volume. More people in the ER also means it takes longer to see people. Resources can get stretched. And so even if you yourself are spending your day in air conditioning, if you happen to have your unrelated medical event that day, the healthcare system you rely on may be under a lot more strain than you were expecting when you need your emergency care. So while heat finds the vulnerabilities in our society in a really devastating way for some people, it also puts all of us at risk, even if we think we are safe in air conditioning.
Yeah. So unfortunately, in our recent history here in the United States, we have a really strong example of what it looks like when extreme heat kind of comes and stays with the Pacific Northwest heat dome. How did that play out in terms of demands on infrastructure and like what were some of the lessons learned from that?
Great question. I mean, I was not practicing there. I have looked at some of the data and collaborated with some folks out there on some research related to it. I would point at the work of people including Jeremy Hess and many others on the West Coast. A couple of things. Clinically, they saw a huge increase in critical care needs in the emergency department, very high volume of heat stroke. The emergency medical services, so ambulances that need to pick you up when you call 911, got really overtaxed. Response times went up. And then all of this is happening on a background of infrastructure strain, right? So in order for us to provide good emergency care or just stay safe and cool in our house if we have an air conditioner, we need power. We need road systems that are working. And if it's so hot that bridge joints are expanding and you can't rely on mass transit to move around, there's a lot of logistical challenges that start coming up in how do we take care of each other as a society, particularly when it comes to emergency care. When we have looked at data here in Boston, which has not seen temperatures as extremely hot as we're seeing in the Pacific Northwest, we see impacts on operational metrics in our hospitals from heat. And so I think we can see that this is going to be an issue, and we really need to be thinking through what we can do to keep people safe and prevent need for healthcare utilization, because if everybody needs healthcare at once, there's no way to flex the system up fast enough to meet that need.
Yeah. I've seen some reports too that places like New England that are not historically prepared for or historically used to extreme heat can have more extreme results from heat waves because we just don't have the infrastructure. Our bodies aren't acclimated. Is that true? Do you see that?
Yes, and I'm going to provide an anecdote and then maybe look at Amruta to share some of the larger scale data on this. Anecdotally, what I have seen is people who are sometimes physiologically not prepared if it's early spring, but also who are living in a culture that is not used to dealing with heat, because that hasn't been a problem here to the same degree. So, a couple of clinical cases I've taken care of. One of them was an outdoor worker working in a sort of an outdoor parking lot environment in really hot weather that in some parts of the world, nobody works during the middle of the day in that type of location. But this is New England. That wasn't the expectation. And they collapsed and actually were treated as a suspected drug overdose because that was the thing people were thinking about. They weren't thinking about heat. This wasn't in the cultural awareness of the group of people around them. And so they got to the emergency department unconscious with very abnormal vital signs and a core body temperature of more than 108 Fahrenheit. And we had to do a lot of critical care stuff to cool them down and provide life support in that situation. And so that to me is a example of a misalignment between the heat risk in that location, hot, humid, outdoor work, and the cultural understanding of that risk, because that was a preventable case, but it wasn't prevented. And I think that's where there's a bit of a mismatch between the risk we're experiencing and what we're actually seeing in practice. And if you look at this big picture, I will hand off to Amruta to talk about that. I think we are seeing some really interesting stuff going on statistically.
Great. Take it away, Amruta. What do you
Yeah,
see?
so a lot of my work deals with big data from the epidemiologic perspective. So kind of continuing with looking at what the data can tell us to support the anecdotal evidence that clinicians like Caleb can bring to the table. So I've looked at healthcare claims data. So this is looking at health insurance claims. I've also looked at electronic health records across multiple healthcare systems around the United States. And interestingly, what we see when we look at the whole country, all of the claims that we're seeing, we do see that, of course, temperature is associated with increase in the utilization of emergency departments, and there's increases in inpatient hospitalization needs as well. But when we parse that out and start to look at regions, so specific regions of the U.S., do we see elevated risks in the Pacific Northwest compared to the South or the Southwest? And you might expect that elevated temperatures are obviously higher in places like North Carolina or Texas or Florida or New Mexico. But what we actually see is that the risks associated with increasing temperature are higher in the northern parts of the United States, so the higher latitudes, places like the northern Great Plains, New England, Pacific Northwest. And we think that's telling a story about adaptation strategies. So maybe in the South, more homes have air conditioning, more public spaces have air conditioning. People are used to extreme temperatures or higher temperatures. And so they've created an infrastructure around that. And that's just not the case in Boston. Our homes in Boston are very, very well acclimated for the cold. But if you think about what that means, is that we have a lot of insulation in our homes. We're trying to prevent heat from escaping in the winter, which is really important. But then you flip it, and in the summertime, we're still preventing the heat from escaping. So sometimes inside people's homes can also be elevated temperatures, a few degrees warmer than what we're even seeing outside in the ambient temperature. And I think about this a lot, particularly in the electronic health records data and also in the ED utilization data that we see among patients who are uninsured or patients who are publicly insured, and especially people who have unstable housing or people experiencing homelessness. So we tend to think about, if you have a home, you're likely to be less vulnerable to the effects of extreme heat exposure. But I think where we need to start thinking about this is what types of resources do you have in your home? So if you have a house, and even if you have an air conditioner, if you don't have the ability to pay for the electricity that you need to run the air conditioner, it's not guaranteed that your home space will be any cooler than the ambient environment. So I do think that, again, the data is presenting us with this picture that people who are unused to extreme heat are the ones maybe that we need to be a little bit more worried about. And I think going back to the previous example, Sabrina, that you talked about with Caleb, to me, that's what was happening in the Pacific Northwest as well. It's just that a place that wasn't used to experiencing this type of extreme temperature for this extended period of time. That's also important. It wasn't just a day or two, it was a more extended heat wave. We'll start to see some of these similar effects exacerbated over time.
Yeah. I'd like to stay in this idea of place-based risk. Because as we were talking about before, it can be just a matter of a couple blocks that one place is sweltering and the other place is hot but livable. So what are some of the things that makes the really hot neighborhood so much hotter?
Yeah, that's a great question. And we talked a little bit briefly about the urban heat island earlier. So I want to describe that in a little more detail. So in urban environments, we have a lot of resources that we think are very important for population. So we have good roadways, we have good sidewalks, we might have a lot of buildings, very tall buildings, apartment buildings or office buildings, et cetera. So these are the features of an urban landscape, right? But these also are the things that might lead to elevated temperatures. So if you have increased paved surfaces, and a lot of that is dark paved surfaces, that's attracting and keeping a lot of heat in that environment. If you have large buildings that don't have reflective surfaces or have dark windows or dark features, that's also going to trap heat near the urban core. Another component is that, and this is something that I think is a little bit counterintuitive, if you have a lot of air conditioning, the warm air is being circulated somewhere, right? So the cool air is coming in, the warm air is flowing out, and a lot of that warm air stays trapped within that urban infrastructure. So there are a lot of different factors that increase urban temperatures, and this is what we think of as the urban heat island. Now, there are a lot of features that could potentially try to reverse some of those effects. So, for example, green space. We know that parks tend to be cooler than surrounding paved surfaces. There are types of pavement that are actually more reflective that can be used to cool down an urban environment. There's also a lot of greening initiatives for buildings, different types of green design and green certifications that buildings can obtain in order to make sure that the buildings themselves are reflective, or there's some sort of exterior green space, et cetera, that they're being built into those buildings that can help to improve the reflectivity of those surfaces. So I think there are a lot of different tree canopy, built environment, housing quality, access to green spaces. This can all shape the way that the urban environment exposure works. We talked a little bit about the population-based risks as well. So we were talking about place-based. Population-based risks include things like having disabilities, being dependent on medical equipment, people who have longstanding chronic health conditions might be at greater risk. And we also think about older folks, children, people who are living with low income or low socioeconomic status, and then people who are unhoused or unstably housed as well. And I think that those all can combine often with some of these urban characteristics to convey additional place-based vulnerability.
Yeah. I remember one time I often, when I'm writing about a heat wave, I'll be in touch with emergency physicians like you, Caleb, who will tell me what they're seeing. And I remember a couple years ago, hearing about a small, like a 5-year-old who had underlying asthma, and the mom had to make the tough choice of, do I leave my my like almost kind of air conditioned home to get on public transportation and take him to the hospital because he was having an asthma attack. And how much worse and how scary it got on the way there. but that it was ultimately the right choice because he could get the treatment he needed. But I feel like it sort of encapsulates a lot of what you both were talking about, Caleb and Amruta, because this is someone who was not having classic extreme heat stroke symptoms. He was having an exacerbation of this other underlying thing, and all these other aspects come into play. Lisa, I want to turn over to you for a bit. So you mentioned at the beginning an interesting idea that we have to be aware of how to make good choices about the limited resources that we have and how to get the most health benefit from those resources. Wondering if you could expand on that for us.
It's really not any different than any other decision we make to spend money. Presumably, we think about what's good about whatever it is we want to buy, what's bad about whatever it is we want to buy. We think about the other ways we could spend that money, or maybe we just save it for a future day. And we balance those things to determine whether or not to buy whatever it is. For government decisions, or these sort of big public policy decisions, we use a formal version of benefit cost analysis. It's a way of thinking about how to allocate spending. It's well established, widely used throughout the world for these sorts of decisions. What we do is we estimate and compare the costs of implementing different interventions. We compare those costs to the likely outcomes. These might include reductions in the risk of illness, injuries, or death, including those that are both directly related to the heat and what we think of as heat stress, and also the sorts of things that we were talking about earlier, like exacerbation of existing conditions. And we also think about things like the medical and other costs that we might avert. One of the reasons why I think this framework is so important is that a lot of times we have sort of unexamined, almost emotional reactions to different policies. And what this framework forces us to do is to systematically examine the evidence and think very carefully about what it's telling us about the impacts. We've been working on, I should say that the benefit cost analyses of climate-related or heat-related interventions are increasing. I joke about it being like drinking out of a fire hose. As soon as I think I've collected every single one, another 5 come out. But what we've been working on here at the Chan School is some of the interventions that we talked about earlier, providing air conditioners to low-income populations, including helping them install them, monitoring how much it's changing their temperatures, issuing heat health warnings where we tell people that the temperature is getting high enough that they need to change their behavior, painting roofs or other surfaces, as was mentioned earlier, with reflective material to reduce heat. We also tell you about shaded green space, requiring water breaks for outdoor workers is important, and so forth. It's really exciting to see this literature grow because I think as it increases, we get a better understanding of how we can best spend our money in order to prevent the sorts of effects that we're all talking about.
So I'm just going to parrot it back to you a little bit because that's something I sometimes do in my line of work when speaking to people like yourself who are far more smart, more intelligent and educated than I am. So my understanding is what you're thinking about is what are the costs associated with giving a bunch of people air conditioning, installing it, maybe even helping with their electricity compared to the emergency services that they would need, the costs associated with the strain on the emergency department, like what Caleb was describing, like the big picture. So how do you weigh those granular costs versus systemic costs? Is that kind of the idea?
Well, I think there's 2 pieces of that, and one is that in ideal world that definitely does not exist, we would take every single possible intervention, throw them all into a basket, and compare them all, and think about how to allocate our money. We just can't do that. There's far too many things we can do, and it would take far more time and resources to assess them. But the other piece of that is for any particular intervention, we want to think very carefully about what are the costs of that intervention, like your air conditioning example, and what are the benefits. And some of the benefits have to do with the sorts of things that we were talking about earlier, that reducing the strain on the healthcare system, both in terms of cost, in terms of direct costs, how much we spend on medical services, but also in terms of the sorts of problems that Caleb was raising earlier in terms of just having really long wait times at emergency rooms. So we want to balance all those different things and also include in there the fact that, like in your example of the mother with the child with asthma exacerbation, there's a lot of pain and suffering involved there, and we want to make sure that we take into account those effects in our analysis.
So, Amruta and Caleb, I'm going to turn back to you for a bit because I want to talk about this interesting idea that's been kind of percolating in Boston and growing here in Boston, the Boston area, about prescribing access to air conditioners as medical professionals. I don't know, Amruta, maybe you want to take it first. Like, what does that actually look like?
Yeah, so I think this is a program that I've been reading about and looking into, going back to one of the items that I mentioned earlier, which is that for folks who are unstably housed or maybe reliant on public insurance, if we provide them with access to air conditioning resources, but don't necessarily follow up with other types of resources that they might need, it's not guaranteed that their indoor environment would be cooler than their outdoor exposures, right? So the program that I was particularly referring to is that people who rely on Medicaid for public insurance. So Medicaid is in the US, obviously the public insurance program that provides access to insurance for people who are low income. And it's means tested at different levels by different states. So your eligibility for Medicaid might differ depending on where you live. But for example, here in Boston, there's a program where you subsidize the cost of purchasing a window air conditioning unit through Medicaid for people who are eligible. And then there are programs that provide help with installation. There's some other fees that are covered, although I don't think the full cost of electric utilities is covered under that program. There may be some considerations that are ongoing for that program. And so hopefully in the future, we continue to see this type of supportive resource available for the people who need it the most. But again, this is something that really is place dependent. So not all communities have the same access to subsidies for air conditioning or other types of resources. And it really does depend on decisions that are made locally and policies that are implemented locally, which can vary a lot from state to state.
And you were suggesting, I think at the top of this, that if you're just covering the air conditioner and the installation, but not the electricity costs, it doesn't ultimately work. Is that right?
I think it depends. It depends on what types of resources families have available in order to pay for the electricity bill. We can even take the example of the family that you were mentioning before, the mother making a decision about taking their child on public transit. There are some families that are making decisions about which air conditioner unit they should turn on. Do we keep the one on in my child's room so that we can avoid the types of asthma exacerbations or make it possible for them to study so that they can complete their homework for school tomorrow? Or do we turn on the family air conditioning unit in the living room and then everyone is limited to that living room space? There are a lot of different things that might affect people's decision making within their own home environment. And I think each of those can have different implications for what the greatest threat might be indoors. But yes, I do think that having the first part of providing the air conditioning unit without necessarily thinking through the resources that would be required in order to make sure that they have the cooling that they need from that air conditioning unit in their home, we have to be thinking from this bigger picture perspective.
Yeah. Caleb, can you weigh into on the stepped wedge trial that I know you've got some experience with?
Yeah, so I'm a co-investigator on a research program that is based here at the School of Public Health. This is part of a larger effort focused on heat adaptation across several sites. The part I'm involved in is led by Gary Adamkowitz and is being run in collaboration with a number of partners, including communities responding to extreme weather and the family ban. And we've been enrolling people around Boston who are older adults living with some degree of medical complexity who don't already have air conditioning in their homes and have been randomizing people to receive an air conditioner either this year or next year. So everybody winds up with an air conditioner. And in the group that gets the air conditioner up front, they also get some electricity subsidies. Next year, they've got the air conditioner still, but there isn't still an electricity subsidy. So you wind up with three groups of people who have air conditioning with an electricity subsidy, air conditioning with no subsidy, and people who have not yet received their air conditioning. And we're tracking everything from use of the air conditioner, how long is it turned on for, how much power is it drawing, to indoor temperature, to a range of survey-based metrics around things like thermal comfort, heat stress and strain, healthcare utilization, to try and get at some of these answers around how do people actually use this resource if it's in their home? How much does it actually change indoor temperature? And are they using it all the time? What's the actual electricity load? How electricity use responsive are they with and without subsidies? And then do we see impacts on heat stress, heat strain, healthcare utilization that get at some of the impacts and costs Lisa is talking about that are really important for informing how do you design big picture policy?
Mm.
I will say there's also a big piece of this story that is about not the large scale policy benefit cost analysis, but the individual decision making benefit cost analysis of a single human. Is this air conditioner loud? Does it smell good? I have had people I've seen in my clinical practice in the emergency department, unrelated to the research I'm doing, who come in feeling lightheaded and dehydrated. We fix that and we get ready to discharge them. I say, hey, where are you living? What's going on? What's your life like? How did this happen? And I'll hear things like, oh, I do have air conditioning, but it's kind of moldy and it smells bad, so I haven't been running it. Oh, I have air conditioning, but it's broken. In one case, I had a patient who had actually had an air conditioner, it broke. Finances were not the limiting problem. She actually ordered and got delivered a new air conditioning unit. But she was pretty elderly and frail and couldn't install it herself. And so
Mm.
the air conditioner sat in a box in her apartment until she had developed heat exhaustion, and the EMS team had to kick in her door and bring her to the hospital. And so there are all of these human factors dimensions to this, where the logistics of life start interacting with heat in ways that are really hard to predict purely from behind a computer screen. And so getting out into the field and talking to people and like hearing about their lived experience of what does heat look like in their life has been hugely informative. And I think we need more of that as we think about how to roll out policies that will actually get used and actually work for people. Cooling centers are another example of sort of a intervention that makes sense, give people a cool space they can go to, but that has actually been really underutilized for a variety of reasons related to accessibility and whether people feel comfortable going there or simply want to go there. Going to a boring room with air conditioning may not be how people want to spend their day. And so there's a lot of this human factors stuff that has to be done alongside the rigorous statistics to understand what works and the benefit cost analysis to understand does this make sense to fund or not.
Yeah. Amruta, I want to kick the cooling center idea over to you because I know you've looked a bit at how city spaces can be better designed to help and like what works versus what maybe sounds great but isn't actually the solution.
Yeah, that's a great question. And we actually have an ongoing research project that's being led by a postdoctoral fellow of mine right now for the summer of 2026 across 8 different cities around the US. And what we're doing is key informant interviews, stakeholder interviews. We're talking with people who are using cooling centers, people who aren't using cooling centers, people who work in cooling centers to try and understand this very question, because I think we anecdotally know that people aren't necessarily using cooling centers in the way that we would think they would. But I think it's hard to understand what are the barriers? What are the reasons why people don't use the cooling centers? Are there access issues? Are there other types of, like Caleb mentioned, is there anything to do? Are there ways to keep your children occupied if you need to take your kids to a cooling center? That's a big one, I think, for families. If you're a person experiencing homelessness, is there a place where you could lock up all of your belongings if you're carrying them with you? It turns out that's a huge barrier to cooling center use. And so I think there are a couple of different things that we've seen. In the greater Boston area, there are some communities, so we tend to think of it as this monolith, but it's actually 20 plus different cities working together in tandem to try and provide climate adaptation. And in some of the communities, they've just decided not to open cooling centers anymore because people didn't want another place that they had to fit into the logistics of their day-to-day life. Their ask was, please provide us with these cooling resources in the places that we're already using, like community centers or churches or libraries, et cetera. In some places, they're trying out other types of cooling resources and running into some friction between different needs for public spaces. A good example is that in Porter Square, there was an idea to create some shaded areas. This has become a talking point, I think, between the city of Cambridge and the MBTA because the police and security from MBTA is concerned about creating spaces where people may be congregating in public areas. And so I think there's a couple of different things to try and balance in that regard.
So on the one hand,
And
wanting people to congregate, and then on the other hand, fearing that if people congregate, something bad will happen.
exactly.
Yeah.
So I think it's a story of, two different views on what might happen as a result of congregating in a public space, right? So I think, there's just there are all of these different things to navigate when it comes to the social infrastructure as well. Another thing that we're seeing is that people may not have access to the information that they need about the locations of cooling centers. So the city of Boston proper operates cooling centers during extreme heat periods. Those are the same places that they open up during wintertime storms as heating zones as well. A lot of them are the Department of Children, Youth, and Family centers, and they're not necessarily the easiest to get to. So, for example, one of my collaborations is at Boston Medical Center, which is in South Boston. And if you are a person who is in the vicinity of Boston Medical Center and you would like to visit an official cooling center, the nearest one is a 1.5 mile walk away. And it's not necessarily easy to get to on public transit. So another consideration is it's great to have these cooling resources, but are we placing them in high traffic areas? How difficult are they to get to? Could people walk to them? If it's 105 degrees outside, could people walk to them? These are all considerations that I think are really important for cooling spaces. And, another thing that we've been looking at is what are the other types of things that we could provide as more mobile resources for folks as they're moving about in spaces that might be warmer on average. So we've started piloting different cooling kits. And in these cooling kits, you might put an umbrella for shade. You might put some sunscreen. You might have flip-flops or other weather appropriate attire, maybe a refillable water bottle. It turns out that access to drinking water is super critical and it's actually a non-trivial issue for people who are moving about in the urban environment. In the city of Boston, there have been closures of public drinking water fountains during the pandemic because people were concerned about the spread of different viruses. And some of those have opened, but some of them have not reopened. So a person who needs drinking water might have to also be traveling further than they would have otherwise in order to get that, drinking water resource. So, things that can help people to stay more resilient as they're moving through the environment are also very useful cooling resources as well.
Yeah. Lisa, I want to go quickly to you because I'm curious how this fits with your thinking about like the big picture of the resources that are required here.
Well, it's really interesting listening to this because, we, especially Caleb and Amruta, know so much about all the details of these different programs. But if I'm a policymaker, someone in government or maybe a nonprofit that's thinking about, I have X dollars, how do I fund things? I don't have time to, spend lots of time talking to Caleb and Amruta and learning everything that they know that makes things work, doesn't make them work, the pros and cons, the benefits, the cost. What benefit cost, the sort of work that I do is try to bring everything that you guys all know together into a package so I can say to Sabrina, if you need to make a decision, I can say to you, here are all the things put together and what they tell you about what would be the most effective use of resources. When I go out into the, not with these folks, but when I go out and talk to people about heat stress who are not as well informed as you all are, I find that people often get so excited about the benefits of an intervention that they forget that it might not be effective for all the reasons that Caleb and Amruta were just talking about. And they also forget there's costs. I joke about the manna from heaven problem. We think if we have a good idea, the money's just going to come. Or they get focused on the problems like the worry about drug use in create more appealing spaces. And they don't think about how likely those outcomes actually are. Maybe there's, these scary things, there's a very low probability they'll ever happen. And they don't think about, well, okay, so maybe drug use will increase by some tiny amount, but we'll be saving a lot of lives by providing this cooling option. So it's most of what I'm doing is trying to bring together all the stuff that we've been talking about in order to help people think about how to make a better informed decision.
Along those lines, although I guess turning it to more personal decision making, we have about just a few minutes left. But Caleb, I wanted to make sure we get to talk a bit about the climate resilience toolkit that you've been working on. Can you talk a bit about what that entails?
Yeah, so our team at Harvard Sea Change, in collaboration with AmeriCares, developed a climate resilience for frontline clinics toolkit, which has now gone through a few iterations over the years, has actually been deployed by 19 clinics. We were able to do some qualitative implementation research with users of it. And the basic idea is that we know a lot about this problem already. There's been a lot of really excellent epidemiology work done, and we are starting to have some hints as to interventions that may help. And we need to make this information accessible. So, to Lisa's point, thinking about what's accessible to a nonprofit is one question. Another is what's accessible to a patient or a overworked nurse practitioner in a primary care clinic. And so the Climate Resilience for Frontline Clinics toolkit includes a lot of distilled resources on heat that try to take some of the really rigorous science that people like Amruta are doing and turn that into like a one sentence summary that is easily understandable by a clinician who's trying to figure out how to counsel a patient. And so this resource includes information for patients in the form of patient handouts, patient heat action or hurricane planning tools, designed to have sort of fill in the blank. So if it's above a certain temperature in my town, here's the person who's going to call and check on me. Here's what I'm going to do to stay cool. Here's the address of the cooling center if that's an intervention that you're planning to use. And it also includes information for clinicians so that if you're a primary care doctor or a physician assistant in a critical access hospital, you have something that will help walk you through, okay, I have a patient with moderate congestive heart failure, insulin-dependent diabetes, and no air conditioning. Sounds like they're at risk. What do I tell them? And provides some relatively distilled information on how to counsel them about heat and the implications of some of the medication that they're on as well, and what that can do. So this is one example of an intervention that is freely available. And we also need more study on this, right? We need to better understand, like, how do people use this in practice? What type of information do patients actually respond to effectively? And ideally, it needs to be paired with a lot of these other big picture interventions so that if you have the patient with heart failure and insulin-dependent diabetes for whom one of the big things is stay cool, there's a way to do that, whether that's in their home through air conditioning or in a cooling center, if that's the answer, or simply their neighborhood isn't as hot as it would have otherwise been because there's lots of tree cover and reflective surfaces. And so I see these as complementary solutions where we need to have a very team-based approach as a society to addressing this, where we are both looking at root causes, mitigating climate change, doing landscape scale interventions, and also doing policies that are aimed at providing people with cooling in whatever form is necessary for them. And then that also provides this targeted, tailored guidance, which is what this toolkit is about, on how clinics and clinicians can guide individual patients about their risk and their risk reduction.
Thank you for that. So last question to all three of you is sort of a rapid fire style one. I'm just curious, if you could provide a piece of advice for people who are watching this, guidance for them or for them to share about one thing you'd love to see happen to help people and our society in general just address and adjust to extreme heat better. I'm going to go in order. Let's say, Lisa, how about you first?
So I feel like the answer to this is both on a personal level and on a society-wide level. I was just thinking about a story that Amruta told a while ago about how one of the advantages of green space or cooling centers is it brings people together so they notice that other people are not feeling well. And I think we need all of us, not just the medical professionals, need to be better educated about how to identify the signs of heat stress and what to do, so that we take the appropriate behavior and don't do things that make things worse. And of course, you won't be at all surprised to hear that I hope we'll all encourage people to think very carefully about the benefits and costs of different solutions and think about how to support implementation of the ones that are most likely to have the biggest effect.
All right. Caleb, you next.
Know your risk and check on your neighbors. And there's lots of science behind both of those, but I will just say it again. Know your risk and check on your neighbors.
All right. And the final word goes to Amruta.
I just want to pick up on Caleb's check on your neighbors. I think this touches on the points that Lisa made, the points that Caleb made as well. Some of the best protection that we have against the ill effects of extreme heat is just knowing who in your life might be at risk and checking in on them and making sure that they're okay, making sure they know where the nearest emergency department is and how they can get there. It turns out that it's really important to make sure that your neighbors and that your friends and your loved ones are able to get access to the treatment or resources that they need in case they do become ill during extreme heat waves.
And the good news is getting to know your neighbors just generally makes the world a better place anyway.
Right,
so
exactly.
Win-win all around.
All around.
All right. Well, thank you all so much for joining today. This is super interesting. I could ask a million more questions, but we are unfortunately out of time for today. So thank you to the speakers. Thanks to everyone who watched the program. I hope you all stay cool, check on your neighbors, and stay safe.